to us. So he's currently executive medical director of Rajan Eye Care Hospital, and as you can see, she has received the Nari Shakti Puraskar Award in 2019, the highest civilian award. And ma'am has several publications. She has done several eye camps. She has won a lot of awards, trophies, and she has written and recently launched a corneal color atlas for corneal book in AIS 2024. And I think, ma'am, I have seen her giving expert inputs, and I think she's going to help us in tackling such situation and guiding us in this webinar. Next, we have Dr. Rabindranath HM, and an alumni from RP Center AIMS New Delhi. Currently, sir is medical director of Drishti Specialty Eye Clinic, Davangere, Karnataka. Formerly, he was the editor of KOS Journal and chairman scientific committee KOS. Now, sir's special interest is cataract, strabismus, and glaucoma, which perfectly suits our webinar today. And we have three international speakers today. Each of them has their excelled in their field. Dr. Alessandro Rebiolo, associate professor from University of Del Piemonte Orientale, Italy. And Professor Majan M. Sinja, we all know, sir. We have been learning from his videos from YouTube and his academy. And we have Dr. Hajam Yasin. He's a very close friend of mine, and he's very fond of India. And he's an excellent lamellar surgeon, corneal lamellar surgery surgeon. He's going to discuss one important aspect. So, to introduce our speakers today, Professor Majan Sinjab, sir is currently working as professor of ophthalmology at Damascus University, Syria, and clinical professor at the University of Sharjah, UAE. Currently, he's also heading the Department of Ophthalmology at Dr. Al Habib Hospital, Dubai, UAE. He's the founder and president of Sinjab Academic Consultancy and has played a pivotal role in advancing ophthalmic education globally, which we all agree with that because we have been learning from Sir's video a lot. He is the chief co-founder and general secretary of the International Keratoconus Society and currently serving as the president of Middle East African Council of Ophthalmology, Cataract and Refractive Surgery Society. A distinguished educator and examiner, Professor Sinjab serves as a board examiner for both Royal College of Surgeons of Edinburgh and Royal College of Ophthalmology London. And his special interest includes keratoconus, corneal imaging, refractive surgery, intersegment diseases, and ophthalmic education. Through his academic, clinical, and organizational leadership, Dr. Professor Sinjab continues to make significant contribution to the advancement of ophthalmology. And I'm sure today all our delegates will benefit hugely from such lecture. Next, we have Dr. Alessandro Rebiolo, and Dr. Alessandro is an assistant professor and glaucoma clinic lead at the University Hospital of Meggio della Carita. Pardon me if my pronunciation is not right. Università del Piemonte Orientale, Novara, Italy. He also serves as the editor in chief of European Journal of Ophthalmology. And before reading the rest of thing, recently he did a great hands-on workshop program at our annual DOS, and that was hugely appreciated by all our delegates. So I thought, let me invite Dr. Alessandro for this webinar. And he has received advanced glaucoma training for all the renowned institutes across world, like Moorfields Eye Hospital, UCLA, USA. As a distinguished clinician scientist, Dr. Raviolo has been honored with several prestigious awards, including the prestigious Arvo Early Career Clinician Scientist Award and the Palladino Italiano della Salute Award. He is actively involved in international ophthalmic research and education and serves on the scientific committees of both European Glaucoma Society and Società Italiana Glaucoma. So Dr. Rabiola has made significant contribution. He has more than 120 peer-reviewed publication in his name, and his main interest is glaucoma diagnosis, imaging, progression, and innovative approach to patient management. Dr. Professor Hazem Yasin, as I said, he's from is a professor of ophthalmology at the medicine faculty of medicine, Cairo University, and is widely recognized as one of the leading cornea, cataract, and refractive surgeons in Egypt and the Middle East. He does two courses in TOS, one on iris and one on the talc, and both are hugely hit. and he did one webinar with us around 1 year back, and that was the most attended webinar so far for Delhi Ophthalmical Society that year. So he's an internationally respected clinician, educator, and speaker, and I'm sure all our delegate are going to benefit from his talk today. So we have three case presentation. The case presentation one will be by a team from Guru Nanak Eye Center, Maulana Azad Medical College, New Delhi, and Professor Subhash Dadia, Director Professor. And you all know Sir through his work for strabismus in the society's policy. Sir is doing excellent work to promote that field and the society. And he will be the expert panel for that. Dr. Arushi Saini, currently working as senior resident at GNAC, is going to present the case. The next case presentation will be by Dr. Chandni Satani, senior resident from Arvind High Hospital, Pondicherry. And the expert for that will be Dr. S. Kavita, an excellent glaucoma surgeon, and he is going to discuss that case. Third case will be Cataract Plus. Here the plus will be by retina complication, and Dr. Purnamita, working as junior resident at RP Center, AIMS New Delhi, will present the case. And we have two experts for that. One, Dr. Pranita Sahai, currently working as assistant professor at RP Center. She will discuss the FICO aspect when the disease, when there is associated retinal pathology. Dr. Devesh Kumawat, currently working as assistant professor at the Retina Services of RP Center, an excellent retina surgeon and a very good academician. He will discuss the retina aspect of that case. So, and Dr. Anu Malik she's currently working as assistant professor at RP Center. She's going to summarize whatever the thing that we discuss. In Hindi, we call it Sarans for my international guests. It means the recap along with few input of the recent advances. And we are thankful to AIS office bearer as well as other ARC member. With this, I'll invite Dr. Sujata Mohan ma'am to say a few words and then invite our first speaker, which is going to be Professor Senjao.
Profula, it's a great honor to be part of this Cataract Plus webinar. We often come across cataract, complex diseases in cataract, and I think we have an excellent faculty put together by Dr. Maharana for this wonderful webinar. I'm looking forward to a lot of inputs as well as a lot of learning experience.
Professor Sinjab, you can start sharing your presentation.
Okay. First of all, thank you so much for the committee for inviting me to this very eminent and prestigious scientific meeting. It's a great pleasure and honor indeed. Now I'm going to start sharing for the sake of time. Okay. Let me just make the frame. Okay, so hello everybody, and thank you again for inviting me to talk about the pentacam, because everybody knows that Sinjab means pentacam. So, but this time I would like to focus on how to use the pentacam for cataract surgery in the preparation of cataract surgery. Of course, I have no financial interest. We will go through in this very fast presentation detection, or why we need the tomography in general before going to cataract surgery. Nowadays, the cataract surgery is a refractive surgery. It is no longer just cataract surgery, as we know. And this question, why do we need tomography for cataract surgery? It is similar when we say why we need tomography for refractive surgery, such as LASIK, lenticule extraction, or whatever. So it is no more a question. We need it to detect corneal irregularities and ectatic corneal diseases, to detect any previous corneal refractive surgery done to the patient. For astigmatic management, we need it, and for IOL selection. Starting with the detection of irregularities and ectatic corneal diseases, of course, if we miss these irregularities, especially the ectatic corneal diseases, First of all, we will have wrong measurements. We will have wrong formulas, and then we will have post-operative refractive errors, surprises. In addition, we cannot decide how to manage the astigmatism in such irregular cases. So we have to uncover such cases. Now, detection of previous corneal refractive surgery, this is very important because nowadays we see plenty of people coming for cataract who had maybe 20 to 30 years ago refractive surgery, starting from the RK to latest technology, for example, the lenticule extraction. Now, what if we missed those cases? Of course, we will have wrong calculations and post-operative surprises. Now, how to utilize the Pentacam for this? There are two maps, important to use them always before in the preparation, in the workup for cataract surgery. The anterior tangential map, because it will show us the contour of the treated zone, and the relative pachymetry map, it will show us where the ablation was. Okay, the relative pachymetry map will show us minus values where the ablation was. So in this case, we have plus values in the center while minus values in a donut shape, which means that the ablation was in the donut shape. Sorry. Yeah. Now, this is an example, post-hyperopic case. Okay. In this case, as we said, there is a steep central on the tangential map and ablation at the periphery in the relative pachymetry map, as you see here. Now, this is post-myopic. The ablation was central. Now look at this. The ablation was central. So the minus values on the relative pachymetry map are central. And this is post-astigmatic. Now, this is deceiving because usually when we see this, we may not predict. While if you see this post-myopic, you may say, aha, there is something has been done to this cornea and can be revealed better, of course, by tangential and the relative pachymetry map. But in the astigmatic, post-astigmatic, you may miss it. So these two maps will tell you if it was astigmatic or not. As you see, the ablation was on this axis, and you can predict which axis was treated. So this is the periphery of the flat axis. So the patient had previous with the rule astigmatism. We come to the astigmatic management. The posterior astigmatism should no longer be missed, because if we just consider the anterior astigmatism and we implant toric lens, there will be either overcorrection or undercorrection. Usually, if the patient had with the rule astigmatism, there will be overcorrection, or if the patient had against the rule astigmatism, then there will be undercorrection. This is in general, but sometimes the opposite is true. So we cannot predict. So we have to consider the posterior astigmatism. So how to consider that? Of course, the machines, they will measure, the optical machines, they will measure the total. But the Pentacam can tell us the total as well by using the total corneal refractive power in this display, as you see. And we use the 4 millimeter because our optical zone that we use every day is 4 millimeter, not 3 millimeter as the K readings, SMK readings. Now, this is only if the cornea is regular, but if the cornea is irregular, we cannot depend on this total corneal refractive power display. We have to depend on the equivalent K reading given by Holiday report. And we take the AKR, equivalent corneal K readings, 65%. This is how it is named by Jack Holiday. So we consider this rather than that to check the amount of astigmatism and even the axis of astigmatism in this irregular cornea. Why is that? Because when we implant, especially multifocal lenses, trifocal lenses, spiral lenses, whatever, those premium lenses. If we leave 0.5 diopters of corneal astigmatism or more, then the patient will start feeling dysphotopsia, sometimes intractable, and should be treated. Look how we can decide the incision. For example, this is with the rule, against the rule astigmatism, as you see. And this is the amount of astigmatism. And this is the axis, steep axis of astigmatism. It is almost 175 degrees. So the plan, if I want to go on the steep, so it should be temporal. For example, this is the right eye. It should be temporal if my way is to go always on the steep. But if not, then at least I know that I have to use the toric calculator to predict whether I have to use toric lens or not. So you see how we have to check the tomography in order to decide with the location. This is another example. This is with the rule astigmatism. And if my way is to go always on axis, on the steep axis, so in this case, I have to be vertical almost. But what if the patient has, for example, sunken eye or a prominent eyebrow? In this case, I will not be able to do so. So maybe I will plan it on the flat axis, which means that I'm going to increase the corneal astigmatism. And for sure, I have to use toric lens. So all of these information cannot be found without doing the tomography. We come to the IOL selection. Of course, we have to check the corneal wavefront, as we will see now. Now, this is my guide regarding how to select the lenses based on the RMS of the total higher order aberrations. If the RMS of the higher order aberrations are less than 0.35 microns in microns, not in diopters, I'm using Pentacam and Galilei, sorry for this typo here, then I can use any type of lens. But if it is between 0.35 and 0.5, I can use only EDOF, monofocal or enhanced monofocal, so no more trifocal or spiral. And if it is more than 0.5, only monofocal and enhanced monofocal. But if I am using the Cyrus and MS39, then the cutoff values are 0.5 and 0.7 rather than 0.35 and 0.5 microns. Now, how to check that on the Pentacam? Of course, we have to be sure that it is the 5 millimeter, it is the 5 millimeter, okay, diameter that I'm checking, not the 6 millimeter. And I have to be sure that I chose the wavefront of the cornea itself, not only anterior or posterior. And then I go to click all off. Then I select the third row, okay, which is the vertical trefoil, vertical comma, horizontal trefoil. And I click on the center of the N4, which is the spherical aberration. Then the RMS that appears here is for these 5 aberrations. And the Z40 is for the spherical aberration. I check all of them, and then I apply the rule that I mentioned. Just one second. Yes. Now, I have my own, I called it PSIS algorithm, practical subjective IOL selection. I can send it to you later because it will take a lot of time to discuss. But however, why it is subjective, practical subjective? Because it depends on whether the patient wants good near vision, so we focus on depth of focus, or they want sharp distance vision, so we do not focus on depth of focus for reading, all right? In addition, it depends on the higher order aberrations, whether they are normal or abnormal. If they are abnormal because of the spherical aberration, for example, after myopic treatment or after hyperopic treatment, or maybe because of coma or trefoil. So according to that, I have these two charts. For example, if the patient has very high positive spherical aberration after myopic ablation, for example, in this case, we may want to implant those aspherical lenses that they produce negative spherical aberration in order to compensate for. This is just general rule. So let's say as a take-home message, the pentacam is very essential to detect corneal irregularities and ectopic corneal diseases, to detect any previous corneal refractive surgery, to avoid using wrong formulas in IOL calculation, to plan the astigmatic management, and for IOL selection. Of course, much more is in my 5th edition of Pentacam, 2 volumes. I will be happy if you take them. And as well, I have the same for the MS39 and Cyrus. I called it OCT-based tomography. Thank you so much. You can message me on my email anytime. I'm happy to answer any question. Thank you so much again.
Thank you so much, Professor Sinjab. That was an excellent talk. And I think I'll invite you in future for a 1 hour lecture on this topic, because I think this is a very important topic and every cataract surgeon should know that. And I would like to request our chairperson, Sujata Mohan ma'am and Ravindranath sir. Ma'am, would you like to
Sure.
ask? Yeah,
Yeah.
ma'am.
It was a very interesting talk, Dr. Sinjab, because I've been using the Pentacam since 2008, but I never really used it for this purpose. And we always rely on the eye trace, which we have for looking at the aberrations. But I think this is very interesting, and definitely I'm going to look into it in the future. And also, I think there are other complex conditions which you can, other than keratoconus and ectasias, even Fuchs dystrophy and other things like that, you can actually detect on the Pentacam. And definitely it's a very useful tool even for a cataract surgeon. Thank you.
Yes. Thank you so much.
Any other comments from our international speakers, Dr. Alessandro and Dr. Hazem Yassin?
But I
Or
think
else we move on to the next talk.
next talk.
Okay, so we'll move on to the next talk of this session, and the audience questions will compile and present at the end of the session. So our next talk is about how to approach a cataract patient when there are some coexisting corneal abnormalities, and it's none other than Dr. Hazem Yassin is going to present that. So Dr. Yassin, welcome. The stage is yours.
Well, thank you very much, Dr. Pravola, for this kind invitation. And thank you very much, Dr. Sujata, for being here with us. And today I'm going to talk about phacoemulsification in corneal disorders. I first have to thank Dr. Sujata and Dr. Ravindra Nath, of course, my dear friend, Dr. Pravola, and Dr. Shetra. So cataract and corneal comorbidities is a long course. Actually, I give it in 90 to 120 minutes, almost 2 hours. But we will focus on combined cataract and corneal transplantations, whether we're going to talk about PKP, lamellar keratoplasties, anterior and posterior keratoplasties, whether it's simultaneous or sequential, and if sequential, which is before which. And we are talking about the visualization issues and the biometry issues. So the dilemma of open sky in penetrating keratoplasty. Well, we should think about the pupil dilatation followed by constriction, because we need to dilate while removing the cataract. Then we need to constrict while after implanting the intraocular lens. Of course, we have to talk about the CCR in open sky and how to avoid the radial extension. Then we should think about the nucleus extraction through the CCR. Are we going to put the release incisions or no? And then we're going to talk about irrigation, aspiration, IOL implantation, and all of these very possible vitreous pressure, positive vitreous pressure, and how we are going to deal with it. So can we think outside the box? Yes, this is my role today in order to give some sort of ideas how to remove the cataract and do the irrigation aspiration and implant the IOL in a closed system before doing the penetrating keratoplasty. Many things to be considered. Number one, if there is visibility to remove the cataract before removing the cornea, and are we going to use a fiber optic assisted maneuvering, and are we going to do manual stromectomy or no? So in all penetrating keratoplasties, we're talking about the visibility. We can remove the cataract with the use of the fiber optic, or we can do manual stromectomy before removing the last part of the cornea in order to remove the cataract while it's in a closed system. No, it's not visible. So here is a case where I'm having a single-eyed patient, 90 years old, and as you see, there is a dense corneal opacity, and the patient is refusing to do a penetrating keratoplasty because he lost the other eye through penetrating keratoplasty. And he has a vision of hand movement. So now as you see, I'm removing or cutting the synecdoche, anterior and posterior. Then I'm putting my Boris Malugan ring. But here, as you see, I'm using the fiber optic. And I hope that all the viewers can experience or at least feel that I can see through the fiber optic, although the corneal opacity is very deep. And here I would rather recommend that all my colleagues use the fiber optic first in a clear cornea. So you shut down or you switch off the light of the microscope, use the fiber optic so that while using the fiber optic through a clear cornea, you will be acquainted of how to use the fiber optic when the cornea is opaque. Of course, you're going to use a stain in order to give color contrast, and then I switch on, I switch off the microscope whenever I need it. Then I'm doing the phaco. Under the fiber optic, this means that I can see the maneuvering and I can have a good depth perception. For the sake of time, here I'm using the, can you see this? This is the AC maintainer. It will be the irrigating tool while I use the fiber optic as to dilate and to use my other hand for irrigation aspiration. So now I'm implanting my lens, putting it inside the bag, and then I'm going to remove the Boris Malugan ring, but I can make sure that the IOL is in the bag. So the presence of AC maintainer will save this hand for the fiber optic and make my right hand for the surgical maneuvers. So the gain of this patient is that he regained kind of like 1 or 2 meters because this 90 years old patient, he wanted only to go to the, I'm sorry. So he wanted to gain 1 or 2 meters to go to the bathroom, to go to the kitchen, to feed himself. And this was the maneuver I gained here. So using the fiber optic. Can we do the partial open sky like CCR and nucleus delivery? And then after that, you put your graft and you take the 8 sutures and continue irrigation, aspiration, and IOL implantation immediately after the nucleus delivery. So here I changed the parameters. I'm going to do the CCR and the nucleus delivery in an open sky, and then stop once I did the nucleus delivery. And then I'm going to do the penetrating putting my graft, take the 8 sutures. Since I can do the irrigation aspiration in a closed system with the 8 sutures, I can see through the new cornea, and I can implant the intraocular lens while it's closed. So I changed the order of the events. What is the preoperative preparations? Number one, reduce the vitreous pressure. Number two, IOL calculations, type of the dilatation, and never surface anesthesia in penetrating keratoplasty. It should be general anesthesia. So here is the mannitol. We all know about it, but my adding is I'm not going to put it like an intravenous drip. I'm going to give it intravenous bolus injections, around 20 cc's injections in 10 syringes, and this will give immediate response with dehydration of the vitreous, not to wait so much long time. And of course, I can give the acetazolamide intravenous injections, and it decreases the pressure as well. So here is the Honen balloon. I know that many of our residents, they didn't see the Honen's balloon before. So the Honen's balloon is like the sphygmomanometer, where I put the designed ball over the eye, and then I switch on, or I press for 1 minute and then deflate for 1 minute and press for 1 minute. And you can see here that there is like an indicator for the pressure of the eye in order not to induce any harm to the optic nerve. Of course, we have to put a Flyranga ring for any case of penetrating keratoplasty. So as you see here, I'm putting the Flyranga ring because in open sky, you might lose the pressure or you might have a vitrectomized eye. So the presence of the Flyranga ring well centralized will keep the scleral wall versus the ring, and this helps a lot in suturing without any kind of collapse. If we are going to dilate the pupil, so in such a case, you are going to insert the dilators through the limbus, but before opening the graft, you can see here that I'm implanting or inserting my CTRs in the extreme periphery before removing my graft. Now I can dilate and pull through. If I'm going to do the cataract and IOL before trephination, then I have to put the scleral wound. Why? Because it's extremely important to understand that if I'm going to put a corneal wound, this means that it will interfere with the sutures. So it's extremely important that I'm going to plan for a scleral wound. Then I can do my rexes through the scleral wound. And later on, put in mind that my graft bed junction is away from the suture, which is going to close the scleral wound. Then now you can understand that the scleral wound is closed. And now I can continue my penetrating keratoplasty, but I remove the cataract before removing my graft. And now you can appreciate that if I'm going to put the sutures here in the bed graft junction, it's completely separate from the scleral wound. So the wound construction is extremely important because here is the cataract wound and here is the sutures for the grafting. For the CCR versus can opener, always stain whether it's an open system or a closed system. Why? Because when you stain, you make the behavior of the capsule in a controlled manner. And at the same time, I'm going to talk about the CCR while I'm on open system. I have to press the nucleus backward. Once I open the anterior capsular axis, then I push with the cystotome in the central part of the nucleus, pushing it backwards so that I'm counteracting the pressure which comes from the vitreous, as if I'm eliminating the positive vitreous pressure. So never do the scleral depression, and we are going to deliver after tumbling. Never do the pressure here because you might extend the CCR. Here you can see that I'm going to cut the synechia, remove the membrane. And then do the stretching. And as you see, I'm staining the capsule so that the behavior of the capsule is a little bit tough and I can see it. Then I'm going to do the tumbling from both sides, and then I'm going to remove it in a vertical position. Now here you can see that I'm going to do the staining. And here what I'm saying, I'm going to stop here. Please press the nucleus backward with the cystotome. So you press the nucleus backward, it will counteract the positive vitreous pressure so that you will have a proper sizing of the rexes without radial extension. Am I making myself clear, Dr. Pravula?
Tell that once again. Can you repeat that?
So what I meant here that I'm going to, after staining, here you can see that here is the initial cut with the cystotome. Then I want to make sure that it's not shown here in the video, but with the cystotome, you are going to press the nucleus backward here.
Okay.
You're going to press the nucleus backward, you will control the positive vitreous pressure. This will make the CCR much easier and more controlled without any positive vitreous pressure, so there is no radial extension. Once I deliver the nucleus, I will take the 8 interrupted sutures after the nucleus delivery, and I will start irrigation aspiration in a closed system together with the IOL implantation. Because with these sutures, I can do a proper irrigation aspiration with bimanual, not using the Simcoe cannula, and I can implant even an IOL through this space as if it's a wide phaco incision. So this means that I segmented the steps, delivery of the nucleus and the CCR before putting the graft, then you put the graft and you implant an intraocular lens. Some unpredictable situations like this, where you can find that once I remove my graft, I'll find that the IOL is bulging. So I need to do a vitrectomy, and then I do open sky pupilloplasty. And I can use the 10-0 sutures, as you see here. It's mentioned in textbooks, the biodegradation. Believe it or not, this case is done like 12 years ago, and the sutures are still there inside the anterior chamber. Then I put my graft. Sometimes I have a situation like this, where I take my markings and I do my trephination, and I do my big bubble. But I decided that because it's type 2 bubble, I'm going to change my speculum. And because the anterior chamber is bulging, and suddenly the patient squeezes because it's under general anesthesia, you can see here what's going to happen. Exchanging the speculum, a catastrophe happened. Everything ruptured, the lens was exposed. Can you see it in slow motion? Now the lens is getting out together with the vitreous and the Descemet's membrane. Then now I have to do a Yamani, open sky Yamani, and to put my graft after putting my IOL and doing the vitrectomy. Very wide refination like this case. So I have to trim. And take my sutures, then I'm going to remove the cataract through the main incision. Now, because I exceeded my time, I have the anterior lamellar keratoplasty section, and then I have the posterior keratoplasty lamellar keratoplasty section. But for the sake of time, should I stop here and then I give Dr. Alessandro the talk, and maybe if we have enough time, we'll continue the anterior lamellar keratoplasty, or we have time so that I continue the anterior lamellar, posterior lamellar? It's your call. Dr. Pravola? Dr. Pravola, I already exceeded my time. So this was the part of the penetrating keratoplasty. We still have the section of the anterior lamellar keratoplasty and the section of the posterior lamellar keratoplasty. Shall I continue, or shall you give the
You
talk?
can show at least one videos for each category,
Okay.
then we may conclude.
Okay.
One for ALK and one for PLK.
Okay, for this is the anterior lamellar keratoplasty, and here we will have type 2 bubble. So if we have type 2 bubble, we cannot continue except if we put our graft. So I'm doing lamellar dissection, then I'm continuing my I'm putting my graft first because it's type 2 bubble. And then once I finish, I open my scleral wounds after putting my graft, and I will do my phaco. Then I will implant my IOL. So this means that I did the DALC. I put my graft, then through the graft, I can see the cataract. And then I'm implanting the lens. So this is if I'm going to do DALC. Another DALC. And then for the endothelial keratoplasty, are we going to put it before or after or simultaneous? What about the side ports and the keratoma incision length not to interfere with the diameter of the endothelial tissue? Diameter of the rexus to keep the IOL properly in the bag. The IOL should be hydrophobic, otherwise, if it's hydrophilic, it will opacify from expansile gas contact. Anterior chamber depth and other conditions may change DMEC from straightforward to challenging, then shift from DMEC to ultra-thin dissect. And here is a case of DMEC, but we have ICE syndrome. So I'm going to remove the cataract, but as you see, there is peripheral anterior synechia 360 degrees. So notice here that the Descemet membrane will iatrogenically detach. Then I have to be ready after removal of the cataract with my DMEC tissue. So the Descemet membrane is attached to all the iridoscetic iris leaflets. And as you see, I have to stain the membrane in order to remove it properly from above the surface of the iris, flushing it. And then after removing the cataract, and doing my rexes, then implanting the intraocular lens, and then eventually I will end with removing all the iris tags, then implanting my descemet tissue, and then fixing my tissue with the gas after folding the membrane and then injecting the air. And here is my S mark. I believe that it's a very long course, so I'd rather shift to Dr. Alessandro, and then if we have enough time, we can continue. We have a lot of videos, different lamellar keratoplasty techniques with cataract removal.
Excellent talks, Dr. Yazin. I just have one question. Have you tried chandelier elimination for doing in patients with dense corneal opacity? That also can be done when you put the fiber optic through the pars plana instead of on the anterior chamber, because then it restricts your movement because you have to do a single-handed phaco. That also is a good method of doing in case of a dense opacity. The other thing I wanted to ask you was, it is a very difficult case, but did you have a backup plan in case there's a nucleus drop or some complication, which because the density of the opacity was so much, did you have a backup plan or have a tissue on hand just in case you have other complication and have a retinal surgeon on hand or something like that for that case?
So let's go to that video where it shows the opacity. So it will be showing while I'm answering the question. So Dr. Sujata, thank you very much for the great question. Regarding the fiber optic, we have two types of fiber optic, either the handheld fiber optic, and then you can go through the anterior chamber. But your question, can we use like the chandelier illumination, which goes through the pars plana? Yes, we can do that, but only in one condition: if the cataract is not mature. So if the cataract is not mature, it will reflect the red reflex and it goes through the cataract, and I can see it through the anterior chamber. But if the cataract is mature, then you have no other option except using the handheld limbal approach fiber optic. Does it make sense? Is it clear?
Correct.
So we have two kinds of fiber optic, either through the anterior chamber limbal approach, if it's a mature cataract, and if it's not mature cataract, then we go through pars plana, the chandelier illumination. This is question number one. Question number two, actually, if we have a dropped nucleus, then at this moment we have to open 4 points of pars plana trocher's cannula to put through the chandelier illumination, and then use the fiber optic and the irrigation aspiration in the anterior chamber and do the vitrectomy through this opaque cornea, but with the chandelier, so that you have the other hand using the chopper through the anterior chamber, or just using a fragmatome through the pars plana. And you should, I think, if you master the vitrectomy as far as you master the anterior chamber technique, then there is no problem that you can phaco the dropped nucleus through the vitreous cavity.
Thank you.
You're welcome.
We'll move on to the next speaker, Dr. Crawford.
Yes, let's move on to the next talk by Dr. Alessandro. So he's going to tell us about phacoemulsification or cataract surgery when there is coexisting glaucoma is also there. Yes, Dr. Alessandro? Yeah.
Thank you very much. Can you see my screen? Yeah?
Yes, we can see that.
Thank you very much for having me here. It's a great pleasure. I do have some financial disclosures. I collaborate with many companies. Some of these companies may have, may have some interest in the topic of this presentation. Now, this presentation is gonna be targeted for a general audience. So we don't want to make things too much complicated. I want to give you some key messages when you deal with patients with glaucoma and cataract. And in general, you will see that, I do believe sometimes you go to meetings and you see very complex cases. You got colleagues saying that, the cataract surgery in glaucoma patients may be very complex, but I do believe that any competent cataract surgeon may plan and execute well a cataract operation in a patient with glaucoma, but with some special considerations. And of course, when I refer to competent cataract surgeons, I mean that you need to be able to, manage white cataracts, synecholysis, using hooks to dilate iris or to support a weak zonule. And if you're also doing some mixed surgery, you need to be proficient with intraoperative gonioscopy. Now, what are these special considerations that we need to have when we deal with this kind of patients? First of all, it's very important to be on the same page with the patients. Sometimes patients have got, excellent expectations from cataract surgery. And we know that especially patients with advanced glaucoma may have limited visual acuity improvement. Needs to be informed about the increased risk of complications that the glaucoma comorbidity carries. We will see the kind of IOL that is best to avoid in glaucoma patients. We will talk about combined surgery. And of course, when we plan and execute these cases, it's important to have everything ready. So make sure that you have Harris hooks. You got a nurse that can set up an anterior vitrectomy system if you need, and all sort of things that I'm sure most of us has got in his own theater. So we do have different clinical scenarios when we got patients with glaucoma and cataract. One common scenario is that we may just want to do the cataract operation alone. So doing a standalone cataract surgery. And it's very important to understand that there is a big difference in surgical goals when we talk about open angle versus narrow angle glaucoma, because in open angle glaucoma, the cataract operation has basically a transient and marginal effect of intraocular pressure. It doesn't slow down the disease progression. And the main indication for the cataract operation is not to lower the pressure, but is to improve the visual acuity. It's a different story when we talk about angle closure glaucoma. In angle closure glaucoma, the cataract operation may be considered an IOP lowering operation, which is capable to change and slow down the disease course. And so this is shown beautifully in this study. This is a post-hoc analysis of the ocular hypertensive treatment study, where patients were randomized to receive either medical treatment or placebo. This was a study done in the 90s. You can see that here you can see, the authors analyzed the intraocular pressure changes after cataract surgery in patients receiving cataract surgery and in patients not receiving cataract surgery. And you can see the intraocular pressure went down, but then went back to the preoperative levels within 1 year. Although there was a slightly reduction in the number of medications. We also did, when I was a research fellow at UCLA, we look at the behavior of visual field before and after cataract surgery. And when we look at the visual field rates, we found that the postoperative visual field rates were not affected much by the cataract operation. That means that the cataract surgery in open angle glaucoma is not basically able to change the natural history of the condition. In the primary angle closure glaucoma, it's a completely different story. Here we can do the cataract surgery both to improve the glaucoma control and improve the vision. This is, for example, a patient with a angle closure glaucoma with an intraocular pressure of 20. He was taking 5 medication plus systemic acetazolamide, and then we just did an eventful phacoemulsification. You can see this is a completely different eye. This is an eye with a wide open angle with a pressure of 15 with no medication. So really cataract surgery is very, very instrumental, very important in this kind of patients. And this was beautifully demonstrated by Augusto Azuara Blanco. You may know the Eagle trial. In the Eagle trial, the investigators randomized patients with primary angle closure glaucoma or with primary angle closure and very high IOP to receive either clear lens extraction versus laser iridotomy. You can see from these studies that was published in Lancet that by all the metrics, the clear lens extraction was superior to laser iridotomy. Now, it's important to remember, however, that when we do a cataract operation in a glaucoma patient, we've got an increased risk of complication. The risk of PCR is increased by 2 times. The risk of anterior vitrectomy is increased as well by 2 times. Patients may have more likely to have prolonged AC inflammation, persistent IOP elevation that may require sometimes glaucoma filtering surgery. And also these patients tend to have higher incidence of cystoid macular edema. So this needs to be taken into account and the patient needs to be informed accordingly. What about the IOL choice? Of course, if you use a monofocal IOL, you cannot go wrong. Even if you use a toric IOL, it's fine too. EDOF lens may be an option, especially in patients with early and stable glaucoma, but I will definitely avoid a trifocal IOL in these patients because trifocal IOL may lead to reduced contrast sensitivity, and glaucoma itself may affect contrast sensitivity, and also visual field examination is based on basically contrast sensitivity. So trifocal IOL may affect in a bad way the future monitoring of glaucoma. Also, these patients may have reduced neuroadaptation, and also especially in the setting of, pseudo exfoliation, which is fairly common in my country, you can have in the future, you may have a decentration and tilting of the lens. Now, nowadays, very popular combining cataract surgery with trabecular meshwork or suprachoroidal mix. This is a video, for example, of a mix that I commonly perform, which is called Hydrus. Hydrus is combined with, and these mix are combined with cataract surgery. I don't usually perform them standalone. They do have a mild IOP lowering effect, and they are indicated in patients with open angles, mild to moderate glaucoma that are fairly stable. And the goal of this surgery is basically to reduce the medication burden in the postoperative period. And there are trials showing that if you combine cataract surgery with a mix, you may have a better IOP reduction, slightly reduced pressure, so about 2 millimeters extra IOP reduction, and reduced need for medication. But most importantly, studies have shown that combining cataract surgery with mix may reduce the need for future filtering surgery and also may lower the visual field progression rates compared to cataract operation alone. We can, of course, combine cataract with trabeculectomy. I do love trabeculectomy, is the operation that I perform the most, but I usually do not combine cataract surgery and trabeculectomy because cataract surgery is known to cause prolonged inflammation inside the eye. This is a study done at Moorfields Eye Hospital in 25 years ago, where they measured the flare inside the anterior chamber, and the authors found persistent flare after phacoemulsification up to 6 months after surgery. And we also know, this is a case control study done by Joe Caprioli at UCLA, that when you combine cataract surgery and trabeculectomy, you tend to have worse outcomes than when you do a stage operation. So what I do in my clinical practice, I do a stage surgery when I got a patient with an uncontrolled open-angle glaucoma and cataract, and I do first trabeculectomy first. Then I wait at least 6 months, ideally 12 months. Then I perform a clear cornea phacoemulsification. I do perform a mitomycin C deposit at the end of the surgery, and they also put the patient on high-frequency topical steroid in the postoperative period. We can also combine cataract operation with bleb-forming devices. These are the Xangel stent, and this is the Persephone micro shunt. I'm not sure you do have, I'm sure you don't have the Persephone micro shunt in India because you don't have Santen in India, so as far as I know. But anyway, these are basically bleb-forming procedures that use a device, and these are basically variants to trabeculectomies. But as trabeculectomies, they tend to have a higher risk of failure when combined with cataract surgery. They are less effective than trabeculectomy, and I usually perform them in mild to moderate cases when the target pressure is not very low, when I want to minimize the postoperative visits because the postoperative course is very smooth, and they may be useful. I don't do many of them, but I think they may be useful if you don't have an experienced glaucoma surgeon around, because they are easier to perform and to manage than a trabeculectomy. And we did a study, we published a study in the American Journal of Ophthalmology where we look at the risk factors for failure in patients undergoing microshunt implantation. And you can see here in this red box that the combining microshunt with cataract extraction was lead to a 50% increase in the risk of failure. So I tend not to combine the surgery, and the similar results were recently published in the same journal by a Japanese group. We can also combine cataract operation with tube surgery. I know that in India you do a lot of Hamed valve, and usually, the tube surgery is quite resistant, robust to inflammation. So cataract surgery has little effect on long-term myopia controls in patients undergoing tubes. And so one may consider combining tubes with cataract surgery to improve vision, but also to open up the ciliary sulcus. This is, for example, a case of a patient with a earpiece or peric uveitis. You can see here endothelial deposit. You can see some cells in the AC, but most importantly, you can see 360-degree peripheral anterior synechia. So you don't have any space to put a tube in this eye in the anterior chamber, because that means going through the cornea. What you can do is, as you can see in this video, you can take the cataract out. So you remove the lens basically. But the goal of removing the lens in this case is basically just to open up the sulcus so that you can, as you will see shortly, you can insert the tube behind the iris into the ciliary sulcus, okay? All right. So to conclude this presentation, so when I got a patient in front of me with glaucoma and cataract, I asked myself a question: what is gonna be the most important thing to address right now? Is this patient gonna be, what's the main problem? It's the cataract or the glaucoma? If it's the cataract, I'm gonna do cataract surgery, plus or minus mix, if the patient has got open-angle glaucoma. If the patient has got primary angle torsion glaucoma, and the cataract surgery may address both the visual acuity problem and the pressure problem. But if the main problem is uncontrolled glaucoma, I'm gonna go for a glaucoma surgery first, and then I'm gonna take care of the lens in a second operation. And usually when I also do a cataract surgery after a glaucoma surgery, if the previous surgery is a trabeculectomy, I tend to wait, so I don't want to rush in a cataract surgery soon after a trabeculectomy. I wait at least 6 months. I control inflammation. I do steroids and MMC deposit, and I try as much as I can to protect the bleb to minimizing the postoperative inflammation. If I do a tube shunt on the other end, it's okay to combine, and also you can be a little bit more relaxed in the postoperative course, because usually the tube shunts are very robust, resistant to the inflammation caused by the cataract operation. And that's the end of my presentation. And thank you very much for the opportunity to be with you today.
And thank you, Dr. Alessandro. That was a wonderful lecture. Can I ask you one thing? I might have missed that during your presentation. We get a lot of pediatric patients, ophthalmos patient, who are having total cataract, and there is a they have undergone this trabeculectomy plus trabeculotomy. So, any practical tips for such kids? These kids are 2 years, sometimes 18 months.
So that's a completely different story for a few reasons. First of all, in the kid, you have to take the cataract out because you can have amblyopia, right? So that's important. I don't really perform many. I don't like performing trabeculectomy in kids. Okay, because they're very difficult to manage, because if you have to remove to do a needling or remove a releasable suture, you have to bring the patient back to theater and perhaps doing a sedation or general anesthesia. We know that the higher the number of general anesthesia, the worse the outcome of the developmental delay in these patients. So in this patient, sure, you can take the cataract out. The first line treatment is usually some kind of angle surgery, like you may either do trabeculotomy or goniotomy if the cornea is clear enough. And then if it doesn't work, I usually move to tube surgery, because tube surgery, you don't have to do post-operative manipulation as you do with trabeculectomy.
Thank you. Any comments?
Actually,
Yes, sir.
there are two things. One, taking the lens out in angle closure glaucoma depends on which stage of glaucoma you're operating. If it's an acute angle closure glaucoma kind of a thing where lens is really contributing for the angle closure, definitely it helps. But in Indian subcontinent, we see a lot of patients who have almost normal depth of anterior chamber, but it's synovial closure, progressive synovial closure rather than lens contributing. So in those cases, maybe removal of lens may not help that kind, like removing the lens in acute angle closure glaucoma where lens contributes to the high IOP. This is one. So those kind of things usually we manage as if like open angle glaucoma plus a peripheral iridotomy. So do a peripheral iridotomy and literally doing a PI converts a chronic angle closure glaucoma into a primary open angle kind of glaucoma in terms of management. So then it's a medical management and surgery, number one. Second, see in Indian subcontinent, we get lot of mature cataracts with advanced glaucoma. Those kind of things, and with such a socioeconomic background, it is very difficult for them to call repeatedly for follow-ups. And that's why in India, it's very common to do a combined surgery, cataract and glaucoma, both in terms of small incision cataract surgery or a phacoemulsification with trabeculectomy, and doing really well, especially a clear corneal phacoemulsification and trab at different sites.
Okay.
It's a wonderful tool, and they're doing well. Yes, I agree. Compared to two different sittings, trab and cataract, doing a single sitting trab and cataract combined surgery slightly increases the chances of blood failure because of inflammation, as you rightly said. I think if you manage it correctly by strict follow-ups and doing titrating the topical steroids and inflammation, especially in those cases where there is a total cataract and an advanced glaucoma, it helps, and that still has a role. A combined surgery has a role, especially in a poor socioeconomic status.
I think blood failure has started happening only in the recent decade because of the extensive
Medication.
use of
Medication.
medication. And I've been doing glaucoma surgery since 1990. So we used to have excellent output, and now, of course, we see more and more failures in trabeculectomy. That's the reason why we have to all shift to mix and other procedures. And just like Dr. Ravindranath said, we have been doing combined procedures for such a long time. And probably keeping them on a low dose steroid for a longer time maybe would be the best idea to keep the inflammation at bay. And also the same the socioeconomic status will not allow them to come back again for another surgery.
Of course, I mean, couple of things. I do agree with what you said, especially in angle closure glaucoma. I mean, it's also true that you always have a little bit of lens component, especially unless in very extreme cases where you go, for example, 100% plateau iris. But if you think most of the primary angle closure glaucoma, they develop glaucoma when they're 50, 60, 70. So when you got a little bit of lens component. So I think it's always useful to take the lens out. In
Definitely.
some cases, I do agree that in some cases may not be enough. And so one scenario one case where I do combine surgeries is patients with chronic angle closure glaucoma, advanced primary angle closure glaucoma, where I don't have the time to wait, okay? Because I know that I need to have a very low target pressure, and I know that I cannot afford to wait, because if there is more progression, the patient can go blind. But in most cases, you can perform cataract surgery and see what pressure you get, and if needed, you can do second surgery later. And with regard with your second observation, yeah, I understand. I mean, if I do believe that if you can do a stage procedure, you get better outcomes. So in my hands, I do review auditing all the cases that I do, and the patients that failed in my hands were either combined phacotrabeculectomy or black patients, because those patients have got a higher risk of scarring. So I do think that when you combine, you may have a little bit worse outcomes than if you do the two operations separately. But I see your point in combining, especially for convenience.
Thank you. I think we'll move on with the next speaker. And thank you, Dr. Alessandro. That was a wonderful talk and wonderful discussion. So next, we'll shift on to 3 case presentation. The first case presentation will be from our Guru Nanak Eye Center. Professor Subhash Dadia is going to be the expert for that. And Dr. Arushi, are you there? You
Yes,
can
sir.
start sharing. Yes, please.
So is the slide visible?
Yes.
Yes, please.
Good.
Good evening, everyone. Thank you for this opportunity to present this case of cataract plus strabismus. I'm the presenter and the expert is Dr. Subhash Dadia, sir. Starting with the clinical case, a 58-year-old male came to us with a complaint of inward deviation of the right eye since childhood, and it was associated with diminution of vision. However, he did not provide any corroborating photographs of diminution of vision and of inward deviation in the childhood. The patient had no history of trauma, no history of any spectacle use or occlusion therapy, no history of progression of the deviation, and no history of previous ocular surgery. From his history, we could not identify whether the cataract developed first or the esotropia developed first. On ocular examination, we found that the eye which had esotropia had a very low vision of hand movement close to face with PR accurate, a normal IOP, and a very poor red reflex. The left eye was normal with a 6/6 vision and N6 near vision. On squint examination, the head posture was erect and the facial symmetry was maintained. The extraocular movements were full and free. However, there was no fixation in the right eye, and the left eye had a central steady and maintained fixation. This is a 9-gaze clinical photograph of the patient showing the right eye esotropia with comitant deviation in all gazes and no inferior oblique or superior oblique overactions, as well as no limitations. On a prism bar reflex test, the deviation was found to be around 50 prism diopters. On further ocular examination, we found out the cause for low vision in the right eye. There was a partially absorbed cataract and the posterior segment could not be visualized. So we did a B scan, which was found to be anechoic. The axial length in both the eyes was around 23 mm, which was within normal limits. This is the right eye clinical photograph showing the partially absorbed cataract. So the patient had a esotropia with a very low vision, a partially absorbed cataract, a normal USG B scan, and normal axial length. So our diagnosis was initially a right eye sensory esotropia with a partially absorbed cataract. So the algorithm which we followed to manage this patient was to first remove the cataract, then reassess the strabismus, and then, if required, perform a strabismus surgery as a second stage procedure. So we did a right eye phacoemulsification with PCIOL under LA under GVP, and then planned the patient for squint surgery. This is the surgical video of the cataract. We first did a capsulorhexis, which was found to be difficult due to the adherent nature of the capsule. After completing the capsulorhexis, we did an irrigation aspiration to remove the cataract and then shifted to a phacoprobe. However, after we removed the cataract, we found a central plaque in this patient, as you can see, with the stalk hanging behind, which was suggestive of a persistent fetal vasculature. So we had to clear the visual axis first. So we put a IOL in this patient and then did a vitrectomy of the posterior capsular plaque so that we clear the visual axis, even though we were suspecting low vision in the post-op period. So after this, we found an intraoperative surprise. There was a squint in this patient initially, which was found to have a cataract in that eye, and then a persistent fetal vasculature intraoperatively. So the final diagnosis now changed to unilateral congenital cataract with persistent fetal vasculature and a sensory esotropia. The postoperative status of the patient had a vision of finger counting 1 meter, normal IOP, a well-formed anterior chamber, and a stable IOL. Then we did a strabismus surgery as a second stage procedure. We did a right eye MR recession of 6 mm and 9 mm LR resection based on the findings of the assessment of strabismus at the second stage. So the discussion of this for this case, that patient initially presented for esotropia and was found to have a partially absorbed cataract, the removal of which led to the underlying diagnosis of persistent fetal vasculature, which was missed on the ultrasound B scan initially. There was no microophthalmos associated, and this case highlights that PHPV can present in adults with complaints other than those typically associated with its classical presentation. A staged procedure was planned for the patient to achieve orthotropia. A review of literature of adult presentation of PHPV showed us 2 case reports. One was in an 18-year-old man who had a spontaneously absorbed cataract with PHPV, and in another, just a senile cataract with the intraop detection of PHPV, which did not cause any visual deprivation earlier. So coming to cataract plus strabismus discussion, a unilateral reduction of vision can lead to sensory strabismus at any age. This strabismus can develop within days to weeks of the onset of an acquired visual defect like cataract. In childhood, if the cause of reduction of vision is not removed, amblyopia sets in. A removal of the source of reduced vision can affect the angle of deviation. With a small angle of deviation, removal of cataract alone can suffice in some circumstances, but in patient with large angle of deviation, like in our patient, removal of the cataract would not lead to resolution of the strabismus. So if a patient of, if there is strabismus associated with cataract in children, usually it's a poor prognosis of visual potential. Esotropias are much more common than exotropia in children, and visual deprivation as well as strabismic amblyopia develop in such eyes. So concomitant strabismus is one of the main obstacles to achieve isometropia and binocular vision after a successful cataract surgery. However, according to literature, 32 to 72% of the children may develop orthotropia post-cataract surgery. So in children with cataract and strabismus at baseline, it is appropriate to treat the cataract before strabismus and make decisions about strabismus surgery after cataract treatment. In patients in strabismus and cataract in adults, there can be 2 scenarios. Either strabismus can precede the cataract formation or it can develop as a result of visual deprivation due to cataract. Unilateral cataracts can lead to sensory exotropias, and pre-existing exophoria or intermittent divergent strabismus may decompensate following development of a unilateral cataract. Better outcomes are seen in those who develop strabismus following cataract due to presence of binocularity initially. So the 2 scenarios, if the squint develops after cataract, we perform cataract surgery first and only then a squint surgery, and the prognosis is usually good. However, if the squint precedes the cataract, then a combined surgery can be done or a stage procedure, which we advocate, and the prognosis is relatively poor compared to the first scenario. So there are reports about combined cataract and strabismus surgery done in the same setting, but the drawbacks include less reliable measurements for squint, especially in small angle strabismus, and this can lead to unpredictable results postoperatively because you're assessing the strabismus with a low vision in that eye. However, if one has to do it, then strabismus surgery should be performed before cataract surgery in this setting. Concluding, cataract associated with strabismus presents unique diagnostic and management challenges. Careful assessment is essential to determine the contribution of sensory deprivation and pre-existing ocular misalignment. Early cataract surgery facilitates visual rehabilitation and may improve ocular alignment in selected cases. And strabismus can be associated with a multitude of underlying conditions like PHPV was present in our case and should be evaluated thoroughly before going for strabismus surgery. Thank you.
Thank you, Arushi. That was a wonderful case presentation. I would like to request Dadia sir to say something about the case. Then we'll move on to the next case.
Dr. Arushi has described everything. Basically, this patient was sent to us for cosmetic squint surgery. So in these sort of cases, the main issue is whether you have to do the squint surgery first, or you have to do the cataract surgery, or you have to do the sequential surgery, or strabismus surgery first. These are the four situations. So in most of the cases, we do the cataract surgery first. And basically, if the strabismus is sensory deviation to the due to the cataract, or it is of the recent onset, in those cases, cataract surgery. And in cases where basically you can do simultaneous cataract and squint surgery, where it is stable deviation is there, and adults with poor binocular visions are there. But the problem is in most of the cases, if you do, there is a minimal amount of the strabismus, then that disappears after the cataract surgery. So we have to be very careful. There are some reports in the literature who talks about combined squint and cataract surgery, but we do not advocate that.
Thank you so much. Yes, sir.
Squint surgery is rarely performed as first as compared to the cataract. That is only in cases of sensory deviation with severe torticollis is there. In those cases, squint surgery may be performed, or very severe restriction is there, so that there is problem in the visualization of the visual axis. So in these are the two situations where we can perform the squint surgery first.
The only thing is there are some, like most common clinical scenario is there is a decompensated exophoria because of the unilateral loss of vision of cataract. So those kind of things, sometimes what happens is some people can get reversed. Once you do cataract surgery, they can get back. But problem is sometimes if you can develop diplopia, he can develop diplopia, that's a problem after surgery. So those kind of things will require strabismus surgery in future.
Yeah. Basically, my main intent is I am not in favor of doing both surgeries simultaneously.
Yes, definitely no. When people are not ready to do trab and cataract together, why should you do squint? And
I was listening that discussion. I wanted to make one point, but basically the thing is in cataract and glaucoma, if you do combined surgery, the chances of success rate is 50 to 60%. If you do stage surgery, the chances of success rate is around 90 to 95%. But in our setting where patients, they come for from far and are not willing for follow-up, in these cases, you can do the combined surgery.
okay.
Thank you, Dr. Praful.
Thank you so much, sir, for that wonderful discussion. And Dadia sir pointed out in Indian scenario, all the things, the planning, everything also depends on what is the patient's socioeconomic status and follow up, all this thing. So that was a nice point. And we'll move on to the next case presentations. We are running short of time, so we'll continue with the next two case presentation. And I would like to invite Dr. Chandni Satani and Dr. S. Kavita to, yes, go ahead with their presentation. So they are presenting when cataract is associated with glaucoma, what should be done. Thank you.
Chandni, are you sharing your screen? Yes, ma'am. My slide is visible. Hello. Is my slide visible? Slide
Nadia sir,
visible.
I
You are
think you're.
audible, and please
Yeah,
go
it's
for a
visible.
slideshow.
Just hold on. Just hold on.
Slideshow.
Nadia sir, I think your mic is on.
I'm
Yes. Yes, Channi, you can start.
Yeah. Yes, sir. Just a minute, sir. I'll share my slides. Your slides are seen, shared. Please go for a slideshow.
Yes, we can see your slide. Just go for slide share mode. Channi.
Yes, sir. I'll be presenting, sir. Sorry for interruption, sir. In 1 minute, I'll start, sir. They can see my slides. 1 minute.
You can go to the next presentation if she
Sunil, if you're there, can you please call and help Dr. Channi with her PPT?
Sir, actually, I cannot.
I think some connectivity
Presentation on my.
issue. Yeah.
to the next. Shall we go to the next?
Yeah, Dr. Kavita, can we go for the next case presentation? After that,
Sure.
we'll take.
Yeah,
Yes,
yeah,
sir. I
sure,
think
sure.
Purnamita,
Yeah.
So, Doctor, next we are going to have a case on cataract with retinal disorders, and I would like to invite Dr. Devesh, Dr. Pranita, and Purnamita. Are you ready with your presentation? You can start sharing your PPT. Dr. Chandni, you need to stop sharing. Then only she can share. Yeah.
Yes, sir.
Sunil, if you are there, you can do from your end.
Is it okay now?
No, yours. I think your screen is still being shared. Sunil, Purnamita, you try to share your screen.
hello, sir.
Please share your screen.
Sir, am I audible?
Yes, you are audible.
Sir, is my screen visible?
Yes, it's visible,
It's
Purnamita.
visible. Yeah, you can please go ahead.
Make it full screen and you can start.
Good evening. I'm Dr. Purnamita Saras, junior resident from RP Center, AIMS, New Delhi, presenting a case on cataract with diabetic macular edema. Diabetes can cause early progression of cataract along with diabetic retinopathy. And as per National Diabetic Retinopathy Survey, 7% of diabetic patients develop diabetic maculopathy. Cataract surgery improves the media clarity but may worsen the pre-existing diabetic macular edema due to post-op inflammation and increasing levels of vascular endothelial growth factors, cytokines, and vascular permeability. And combined phacoemulsification with intravitreal anti-VEGF treats both media opacity and diabetic macular edema in the same sitting. Our patient is a 62-year-old male with complaints of progressive diminution of vision in both eyes, left eye predominantly, for the last 1 year. He's a known case of diabetes for the last 30 years with poor glycemic control of HbA1c 10.4 and CBC, LFT, and lipid profile within normal limits. Past history suggests two intravitreal anti-VEGF injections for DME in both eyes, and a focal laser has been done in both eyes 6 months back. The last injection was given in March, Razumab 0.5 milligram, 0.05 ml, and the cataract surgery was done on April, and right now he is on 2 months follow-up. On preoperative evaluation, the visual acuity was 618 in the right eye, improving to 66, and 636 in the left eye, with no further improvement. And on anterior segment examination, right eye had immature senile cataract nucleus creasus grade 2 with cortical cataract, and left eye immature senile cataract NS3 with cortical cataract with posterior subcapsular cataract. On preoperative fundus examination, there was both eye non-proliferative diabetic retinopathy with clinically significant macular edema in the left eye and no diabetic macular edema in the right eye. Here we see there is a focal laser spots seen in the right eye and with some hard exudates. And preoperative OCT, there was loss of foveal contour and increased macular thickness in the left eye with intraretinal cystoid spaces. On biometric examination, we finally decided that we would place a monofocal IOL considering the coexistence of macular pathology. And the specular count was within normal limits, around 3000 in the both eyes. So the diagnosis of both eye moderate non-proliferative diabetic retinopathy with right eye IMSC NS2 with cortical cataract with no diabetic macular edema, and left eye IMSC NS3 with cortical cataract with posterior subcapsular cataract with clinically significant diabetic macular edema was made, and a plan of left eye phacoemulsification with monofocal IOL was with intravitreal anti-VEGF was planned. The rationale for combined procedure is that patient had a presence of like visually significant cataract and persistent macular edema that was that required ongoing anti-VEGF therapy. So that combining the surgery would minimize the post-operative worsening of the edema and reduction in patient visits and treatment burden. Post-op day 1, the patient's visual acuity was 680 with cornea clear, IOL well centered, and the fundus was visible, media clear with NPDR with DME. The patient preoperative vision 636 improved to 618 postoperative day 1, and by 3 weeks it improved further to 612 parts, and a repeat injection was given under day 30, and his vision improved to 6.9 at POD 60. The post-op CP suggests stable retinal findings, no progression in retinopathy, and improved visualization following cataract extraction. And post-op OCT comparison, there was this is a baseline OCT of 580 microns. Post-surgery, post-cataract surgery with anti-VEGF, there was a significant reduction in the macular edema to 411 micron. And on day 60, the CMT reduced to 300 microns. Thank you.
We'll be carrying forward the discussion for the retina and the anterior segment. Dr. Devesh will be sharing the retinal discussion slides.
Okay, so is my slide visible?
Yes, Dr. Devesh is visible.
So I'll be
Go ahead.
discussing the part of optimizing DME treatment when we are considering combination of cataract surgery along with DME. So how does cataract surgery affects DME? Partly, Dr. Purnamita has already told that the surgical inflammation can disrupt the blood retinal barrier, and that leads to increase in the vascular leakage. So there may be a new onset DME that can happen, or the pre-existing DME can worsen. And even DRCR net protocols have shown that even non-center involving DME can convert to center involving DME. So a patient with very good visual acuity before cataract surgery can end up having poor visual acuity in a couple of months. And the risk factors for progression of DME include moderate to severe NPDR as compared to mild or no DR, poor glycemic control, and prior DME. And if we see the natural course, untreated patients will often have worsening of DME that will worsen to its peak by 3 to 6 months in the post-operative period. So the pre-operative assessment remains very important. You need to assess whether the visual loss is explainable by the grade of cataract and macular edema, and the central macular thickness is a surrogate marker of visual acuity, but it shows only a moderate correlation. And you have other features, morphological features such as drill, cystoid degeneration, as well as degeneration of the outer retinal layers, which may suggest macular ischemia or degeneration. And you need to evaluate those features when there is a unexplained visual loss in the patient, which is not explained well by the grade of cataract as well as macular edema. Now, FFA might be required if you want to rule out macular ischemia, or if there are subtle neovascularization, then FFA might be needed. Because if PDR is there, then you need to perform a pan-retinal laser photocoagulation before considering cataract surgery. Systemic control is of utmost important, and a recent good enough control for last 2 weeks is good enough. You need not achieve an HbA1c of less than 7 in patients with diabetic maculopathy, because you need to treat maculopathy because it is sight threatening, and a rapid control of HbA1c to less than 7 uh, uh, can have untoward consequences also. So a recent good enough control of fasting as well as random blood sugar for 2 weeks is more than enough. You need to counsel the patient not only for the visual prognosis, but also that the DME may worsen in the subsequent 3 to 6 months, and treatment might further be required for DME. So, if the cataract is mild and the view is adequate to allow imaging, then you need to treat the DME first. And once the OCT is stable, it is dry for 2 months or so, then you can consider going ahead with the cataract surgery. And if the cataract is significant enough, and or if it is affecting the fundus view and not allowing you to assess the diabetic macular edema properly, then you need to combine the cataract surgery with operative intravitreal therapy. Now, the timing of injection could be before the surgery, maybe 2 to 4 weeks before surgery, or during surgery, or maybe after the surgery, even after the surgery. But it is always better to do it before or at the end of surgery, because the visual gains are better if you do it before or at the end of surgery, because it takes care of the immediate post-operative inflammatory surge and increase in macular edema. After surgery, if you consider injection, then the edema may have already worsened and will also delay your visual recovery. And when you're considering concurrent injection along with cataract surgery, it is very safe, and you should prefer to inject after the cataract extraction has been performed to avoid any upthirst during the cataract surgery. And you can release some fluid from the anterior chamber after you have done your cataract surgery and IL insertion to reduce the intraocular volume before injection. The choice of injection, if the patient is already on treatment, then you may consider choosing the same anti-VEGF agent or steroid implant or steroid injection which the patient has already been on. And in certain situations, steroid implants may act better, such as in chronic DME, or when there is a frequent need for anti-VEGF injections, or there is poor compliance from the patient side, or there are inflammatory component in DME, such as there is neurosensory detachments or hyperreflective dots, then you can consider steroid injections. But there is a need for caution that intraocular pressure rise can happen, and if there is a posterior capsular rupture with the risk of migration of the implant, then that should be avoided in such patients. There are very limited studies that have compared steroid versus anti-VEGF agents along with cataract surgery in DME patients, and they show that the results are not significantly different. And in a recent study, a comparative study by Kelker et al., they have noted that although there is superior CMT reduction with steroid injections, and fewer injections are needed when you use a steroid implant as compared to anti-VEGF injection, but the visual acuity improvements are not significantly different, and post-operative IOP rise might be more in patients with steroid implants. What is more important, whether you use anti-VEGF or steroid, is that you need to assess these patients more closely for the next 3 to 6 months, monitor them with monthly visual acuity and OCT till the DME stabilizes. So the key points being that you need to control the DME if possible before cataract surgery. If the cataract is significant, then you can combine both of these together. You should try to inject as close to the surgery as possible, preferably before or during the surgery, and continuously monitor these patients for the next 3 to 6 months at least. So the next preoperative and intraoperative measures that need to be taken during cataract surgery will be discussed by Dr. Pranita.
Good evening, everyone. So, as Dr. Purnamita has already discussed the case and the retinal aspects have already been discussed, I will be discussing about the pre-op workup pertaining to the cataract. So, as has already been highlighted, the correlation of the severity of the cataract with the BCV is something very essential. And if there is a disconnect, then looking at the retina, doing an OCT is something which is essential so as to avoid any post-operative visual surprises and dissatisfaction on the patient's perspective. Important it is also to assess the maximum pupillary dilation because the diabetic patients often have a poor pupillary dilation. So a pre-op documentation of the maximum pupillary dilation achieved can avoid a surprise in the OR and further chaos during the surgery. Also, it is important that you start these patients pre-operatively on topical NSAIDs, of which nepafenac 0.1% TDS or 0.3% OD is one of the most commonly used drug. This not only reduces the risk of post-operative inflammation and reduces the risk of progression of DME, but also helps in a sustained dilation that can be achieved intraoperatively. In addition to this, bromfenac and ketorolac are the alternates that can be used as a topical NSAID. Next important consideration is about the IOL choices that are very limited in these patients. So if there is a diabetic retinopathy or a maculopathy, multifocal IOLs should not be used in these patients because they can further drop down the contrast sensitivity, which is already compromised in these patients. And in case these patients would be requiring a future laser or a vitrectomy procedure, that can become complicated or difficult in the background of a multifocal IOL. So monofocal IOLs do best in these eyes. However, if there is an astigmatism, toric IOL can always be implanted in these patients. Preferably, these surgeries should be planned under block anesthesia. Whenever you're combining a cataract with an anti-VEGF, it improves the patient's cooperation and the outcomes obviously will be better because these patients have a poor vision, fixation can be poor. And also you can use intracameral lignocaine with phenylephrine, which can enhance the patient comfort and also improve the dilation that is achieved during the surgery. However, despite of that, sometimes you may be in a challenging situation like this, and keeping a pupil expansion device like an iris hook or a Malugian ring should be kept as a backup whenever you're operating diabetic patients to achieve a good pupillary dilation because the cataract often is leathery and brunescent, and with a poor dilation, it is often difficult to deal with these cataracts. Combining surgeries always increase the risk of infection, so you always have to be extra cautious when cleaning and draping and prepping these patients. 10% betadine povidone for periocular cleaning and 5% betadine application in the cul-de-sac area. Betadine wash for at least 2 minutes before you start with the cataract surgery is a must. Now, looking at the surgery that was done for these patients. So routine steps of cataract are, as you can see here, are being done: a capsulorhexis, incision, hydrodissection, delineation, and a vertical chopping technique to remove the nucleus here, and implant removal of the cortex, and then implantation of a monofocal IOL. So here we can see that after implantation of the IOL, completion of the visco wash and wound hydration was done, and only then we took this patient for intravitreal injection. So vernier caliper based marking at 3.5 mm from the limbus, avoiding the conjunctival vessels, a 30 gauge needle was used for intravitreal injection. An oblique entry was initially made, and then a vertical perpendicular entry, and then anti-VEGF was injected. The conjunctiva was pinched. So looking at the post-operative care, in addition to the routine post-operative drugs that you given to these patients, topical NSAIDs is a must that should be given for at least 6 to 8 weeks. Here we gave the patient nepafenac. Also, AGMs may be given in these patients because there can be an initial spike of IOP. So in this patient, we gave oral acetazolamide as a stat and an HS dose. However, in diabetic patients, sometimes there may be a nephropathy, and you would like to avoid it in this patient, and you can give a topical anti-glaucoma in such a situation. And as has already been highlighted, a macular OCT on a close follow-up at 4 weeks and then monthly intervals should be done in these patients because they may often require a repeat intravitreal injection. Even meta-analysis studies have shown that cataract combined with anti-VEGF injection have demonstrated better PCVA and CMT reduction and reduced incidence of DR progression when compared to only cataract surgery in diabetic patients. Hence, good outcomes can be achieved with simultaneous cataract surgery and intravitreal injection. However, there should be a careful case selection and meticulous counseling of the patient for the visual outcome, the IOL selection, and the need for long-term follow-up. So with that, we'll be concluding our case. And Dr. Praful, if we have any questions or I think we are running short of time. So ma'am is there for the next presentation. Sujata ma'am, any comments from your side?
No, I'm not a retina person, but I do see that a lot of combined injections are given, and it again depends on the stage of the cataract and what's the stage of the DME. Obviously, we cannot wait forever for the DME to settle down, so most often it's a combined anti-VEGF which is given along with the cataract. So I think both points are well taken. So we'll go on to the next presentation, the glaucoma presentation.
Dr. Chandni is ready, ma'am. She is with me. Can I share the
Yes,
screen?
yes, Dr. Chandni.
Thank
Sorry,
you.
I
Thank you. I'm
was
sorry
in.
for the inconvenience.
No problem.
Yeah. Get this.
Yeah.
Good evening, one and all. If my slides are visible and am I audible?
Yes, you are. Yes, you are. Please go ahead.
I'm presenting a case on combined cataract plus glaucoma. A 61-year male patient presented with a complaint of defective vision in the both eye for 6 months. He was known case of glaucoma, diagnosed 3 years back, and was started on both eye travoprost eye drop patches. He was lost to follow-up for 3 years, but fortunately, he was compliant to anti-glaucoma medication. He was known case of diabetes and hypertension on treatment. On clinical examination, his uncorrected visual acuity in the both eye was 5/60, which is improving to 612 in the right eye and in 636 in the left eye. His baseline IOP was 24 mm of mercury in the right eye and 26 mm of mercury in the left eye. Now, IOP with anti-glaucoma medication in the right eye was 16 mm of mercury and left eye it was 14 mm of mercury. Central corneal thickness in the right eye was 547 micron and in the left eye 549 micron. On gonioscopy, both eyes showed grade 3 open angles. Anterior segment examination in the right eye showed senile immature grade 2 nuclear sclerosis cataract, and in the left eye it was nuclear sclerosis grade 3 cataract. Fundus image of the right eye showed 0.8 cup to disc ratio with inferior notch, and in the left eye it showed 0.8 cupping with inferior rim loss. OCT, RNFL, and ganglion cell complex was done for both eye, which shows marked loss. HFA 24-2 was done for both eye, which showed superior dense arcuate scotoma. So 10-2 was done for both the eyes. Both eyes showed the superior arcuate scotoma in 10-2. So we have planned for left eye phacoemulsification with monofocal foldable IOL implantation combined with Tonito microhook goniotomy under subtenon anesthesia. So here, after completing the phaco with foldable IOL implantation, Tonito hook is used to performing the goniotomy. The goniotomy is being performed with Tonito hook. On the post-operative day 1, his vision is improved to 6.6 and intraocular pressure is dropped to 10 mm of mercury. He was started on post-operative antibiotic and steroid regimen and he was advised for review after 3 weeks. So this is a paper from our own institute. They have shown the outcomes of combined phacoemulsification with Tonito microhook goniotomy in open angle glaucoma. It is a comparative study in which 2 groups were performed, in which group 1 was combined phaco with Tonito microhook goniotomy and group 2 was phacoemulsification alone. At the end of the 12 months, the IOP reduction in the combined surgery group was around 50%, whereas in the phacoemulsification group, it was 20%. As you can see in the Kaplan-Meier survival curve, The orange line shows the group 1, which is combined surgery. The complete success and the qualified success is around 90% for the group 1 at the end 12 months, whereas it qualified success was around 50% for the phacoemulsification alone group. So why mix? My mix is a ebb interno procedure which gives good IOP control. It reduces the anti-glaucoma medication burden and it has faster recovery time. Usually trabeculectomy is associated with the dreaded complications like hypotony, bone leak, etc. But the minimal invasive glaucoma surgery have less complications, and also it spares the conjunctiva. So in case the patient require future any anti-glaucoma surgery like driver tube, it can be planned for the same. So combining phacoemulsification with MIGS, it gives a solution for the two problems in a single stage procedure with good outcomes. Thank you.
What was the medication the patient was on before surgery?
It's on single prostaglandin analog, madam.
Okay.
Is it
Single
something like
prostaglandin.
KDB? That whatever
Tinnitus.
something
It's
like
not KDB. It is a
something like
microlot goniotomy.
okay,
It's a reusable one. KDB is expensive. The
expensive.
Tanito can be like sterilized and it can be reused.
Is it commercially
So-
available, madam? This thing?
Yeah, it is commercially available, sir. The original Tanito hook is little expensive, but we have the Tanito hooks from the Indian companies
Yeah.
also, Indo-German, and
Indo-
it cost
The
around
yeah,
4,000
problem
to
with KDB is
5,000.
very expensive. The
Serves the
problem.
purpose. Yeah.
So if I just have one question. Suppose a patient has been on a single drug like atenolol or something very, this thing, not a prostaglandin. Would you still go ahead and do a mix in this patient, or do you just do a phacoemulsification and just watch to see whether the pressure is building up again?
Thanks for the question, madam. I think we have discussed enough about our patient profile. So the patients, they really get lost to follow up. The complaints to medication is definitely a challenge. So if there is a definitive disc damage and the patient's presenting pressures are like aligning with the clear-cut diagnosis of primary open-angle glaucoma, we do prefer a combined procedure along with a mix. So we were discussing about the inflammation related to the phaco traps, and I think that has been greatly taken care of phaco mix. However, I do agree that our results are short term. Maybe we just started doing for the couple of years. We have to wait and watch for the long-term results. But at the same time, the good thing is the superior conjunctiva is spared, and if needed, we can consider a trabeculectomy or a GDD at any point of time later.
How often do you follow up these patients post mix?
So this again, like this brings down that follow-up issues also. So after doing the procedure, usually the major problem with these procedures is like bleeding, intraoperative and also post-operative. So we need to do a proper pre-operative assessment, and we need to stop the blood thinners, and we need to ask the patient to lie down on the side of the surgery for a week or so. And during the surgery, maintaining the chamber depth using a high density viscoelastic substance like sodium hyaluronate, and it's like very essential. And it's very essential to form the chamber tightly at the end of the surgery. And all these things helps us to control the bleeding. And once everything is fine, we are usually following up the patients 3 weeks post-operatively, and then like 3 months. Yeah.
Every
No,
3
you-
months, so that
That's
is
the protocol.
no,
Thank you. I think, sorry to the chairperson and co-chairperson. We'll move on to the last section. And the last section
Thank
is,
you.
we call it Saras, that is specific to all the ARC webinars, where one presenter summarizes whatever we have discussed so far. But since we have already crossing the time, we have hardly 2 minutes left. So I would request Dr. Anu Malik to be brief. Just tell us which are the updates over last 1 year on these important topics and whatever we have learned so far. Yes, Dr. Anu Malik.
Good evening, everyone. Sir, are my slides
Yes,
visible?
yes, it's visible. You can go ahead.
So after the insightful and comprehensive presentation by our esteemed speakers, I have this privilege of discussing the latest advances in phacoemulsification over the past few years. So the goal is no longer just the cataract removal, but the precise visual rehabilitation in complex eyes. So a lot has changed in the past few years. And the recent literature emphasizes that the endothelial cell preservation is the primary determinant of any outcome in complex cataract surgeries. We have these challenges like FACD, bullous keratopathy, post-keratoplasty patients, corneal scars, keratoconus, ocular surface disorders, and endothelial dysfunction as well. So the surgeon has to preoperatively phenotype and classify the risk before choosing any procedure. It can be ocular surface, optics, or endothelium that is at risk. A surgeon has to decide, can I see, can I center, and can I rescue based on the location, depth, vascularity, and the grade of opacity. So the recent surgical solutions in phaco and corneal opacities, we have endo-illuminator-assisted phaco, chandelier illumination, intraoperative OCT, and digital image enhancement. These are the recent innovation in visualization that give us the least invasive light and give a safer view. We have slit illumination, intracameral or chandelier and endo illumination, three-dimensional coaxial visualization that is promising in severe grade of opacities, and intraoperative OCT that provides real-time anterior segment anatomy. So real-time intraoperative OCT guidance is increasingly utilized in eyes with poor visualization and compromised anterior segment anatomy. Then the surgical strategies for endothelial protection, we have soft cell technique, low energy phaco strategies, and torsional ultrasound compared with conventional longitudinal ultrasound. We have endothelial protective phaco that has changed, and it's particularly useful in glaucoma, vitrectomized eyes, pseudoexfoliation, and corneal endothelial compromise. Coming to flags in corneal diseases, the results are heterogeneous, and the recent Cochrane analysis demonstrate the uncertain superiority of flags over conventional phaco. The biggest paradigm shift has been seen in Fuchs endothelial corneal dystrophy. From the traditional assessment of just pachymetry and specular microscopy, we assess the Scheimpflug backscatter, tomographic edema, corneal densitometry, and we have AI-based prediction models to assess the endothelial risk. So the endothelial reserve rather than the endothelial count alone should guide the surgical planning. Earlier, and we have studies that favor the earlier combined DMEC triple procedures in visually significant cataract due to faster rehabilitation. This was a meta-analysis in which the 667 eyes were included and 5 comparative studies. So these are the summary of the recent evidence-based advances in corneal opacities. Three-dimensional coaxial visualization improves the red reflex. In Fuchs, we have meta-analysis that are supporting the combined versus sequential DMEC. And in ocular surface disorders, the ocular surface optimization is important. And in keratoconus patients, we have to use specific IL formulas and total keratometry, and the biometry has to be precise. So the surgeon has to see is the case is stable, target realistically, and the IOL choice, we have to avoid the multifocal and EDOFs. So the major paradigm shift is from the cataract first to cornea first decision making. Endothelial reserve is increasingly determining the surgical strategy in endothelial dystrophies, and DMEC, the earlier DMEC has become the preferred endothelial keratoplasty procedure. AI tomography, densitometry, and the predictive analytics are transforming the risk assessment. So coming to phacoemulsification in glaucoma patients, here the major paradigm shift is from the medication escalation only to earlier procedural intervention. And the phaco alone can deliver in angle closure glaucoma, larger pressure benefits were seen because the lens extraction changes the anatomy and also the outflow dynamics. The recent systematic reviews and meta-analysis also support that the combined MIGS and phaco approaches in mild to moderate glaucoma. Phaco alone is preferred in controlled mild open-angle glaucoma, and in phaco along with the mix is preferred in mild to moderate open-angle glaucoma. Coming to angle closure disease, phaco alone in the MIGS and phaco may reduce the medication burden more than the phaco alone in mild to moderate primary angle closure glaucoma. So in angle closure glaucoma, phaco alone opens the angle, but MIGS is considered if sufficient angle structures are visible. So this is the MIGS matrix we have for cataract surgeon in mild to mild open angle glaucoma, phaco with trabecular MIGS. In normal tension glaucoma with medication intolerance, we have phaco with angle-based MIGS, according to the recent studies. And in primary angle closure glaucoma, phaco along with goniosynostosis, along with or without MIGS, depending upon the extent of pass. But in advanced glaucoma with rapid progression, phaco along with the filtration surgeries and the tube shunt may be preferred. So, am I choosing the right MIGS? The practical recommendation is to choose depending upon the disease severity, angle visibility, target IOP, and whether our aim is pressure lowering or the medication reduction or both. So this, what can be added to phaco? The eye stent and hydrus are best for mild to moderate open angle glaucoma. Trabeculotomy or goniotomy is useful, like KDB, trabectome, and GAT variants, when the trabecular resistance is dominating. Canaloplasty, when we have to target the canal system. So we have to decide whether to choose phaco alone, phaco with MIGS, or filtering tubes. These are the major recent MIGS innovation. We have Hydrus, iStent W, OMNI, and Zen Gel Stent, pressure flow. So which MIGS is winning? According to a recent study by Nasri et al., KDB achieved the highest complete success at 6 months among the evaluated MIGS procedures. Coming to IOL planning, we don't compromise future glaucoma care, so monofocal aspheric IOLs are considered the safest. Coming to pseudoexfoliation, along with pseudoexfoliation patients, the meta-analysis data demonstrate that the meaningful post-operative IOP reduction following phaco and exfoliation syndrome and exfoliative glaucoma. We have endothelial protection. That is the new evidence. We have to use dispersive OVD, soft shell techniques, reduce CDE, and elevated preoperative IOP significantly increases the postoperative endothelial cell loss. Then we have AI in cataract surgery in patients with glaucoma. We have AI-guided IOL selections, and the AI frameworks are increasingly being integrated into glaucoma assessment and cataract surgical planning. So the saransh is the endothelial reserve is the new biomarker. Phaco with MIGS is the biggest advance of last 5 years. And the artificial intelligence will influence the surgical planning, risk prediction, and intraoperative decision making. Thank you.
Thank you so much, Dr. Anu, for that comprehensive Saran section. Normally, we do it little longer, but here I think you perfectly did it right. So you just highlighted the latest advances over last 5 years, and just to the for the audience, these are the latest literature. The literature may change subsequently, so these are not guidelines from ARC or this webinar, but yes, these are the new thing that has come up over last 1 year, and you can follow this, and you may come out with some new data. So with this, I think we have concluded almost all the talk, and I would request our chairperson, co-chairperson, and our international speaker if they have any points to make, or else we'll conclude the session. There are a lot of questions. I think I'll answer them individually after consulting with the speaker, because it may not be possible now to answer all those questions. Yes, chairperson, speakers, co-chairperson, sir.
Thank you, Dr. Prafulla, for this wonderful webinar. And I'd like to thank you also for including Tamil Nadu Ophthalmic Association in this webinar, which I forgot to mention earlier. It's been a really wonderful learning experience. A lot of new points, particularly the cataract surgery associated with corneal disorders was very interesting. Thanks to all the speakers and the participants and the faculty.
Thank you. From my side also, thank you, Dr. Prafulla. Now it is time to move beyond simple cataract. So we are coming across a lot of cataract with other complex scenario. It's a nice learning experience. Thank you.
Thank you, sir. Dr. Yasin, you want to make a point?
Well, I claim that I learned more than I intended to teach, because all the presentations were kind of like fabulous. They are very informative. And I believe all the scientific efforts you're doing, Dr. Prafulla, are kind of like unprecedented. Thank you very much for all the efforts you're doing, and for doing some sort of communications with different speakers across this planet. I really thank you, and I'm really honored to be in this meeting.
Thank you
Thank
so
you.
much. Dr. Alessandro, would you like to say a few words before we conclude?
Thank you. It was great. I learned a lot. I really enjoyed both the teachings, all the teachings, really. It's nice to have, such a diverse group of speakers. I think was a, really, really nice and well done event. Thank you very much.
Thank you so much. Professor Sinjab just messaged ki he's in some other webinar, so he might not be able to join back. Thank you so much, Professor Sinjab, sir. That was probably the eye opener for all the cornea physicians who use pentagram only for keratoconus and ectasia. But that can be used for cataract surgery also. And thank you to all the experts. Professor Subhash Dadia, sir, Dr. S. Kavita, Dr. Pranita, Dr. Deves. And kudos to all the presenters because they are all junior resident and still they presented so nicely all the cases. And thank you, Dr. Purnamita. Thank you, Dr. Channi. Sorry that you had some problem with that presentation. And with this, yes, Dr. Arusi, I forgot you. So thank you so much. And as Dr. Yasin pointed out, we were lucky we had speakers from across the world as well as across the country from India. So thank you so much. And Dr. Prashant Bavankule, the chairperson of ARC, he couldn't join because he is traveling. So anyway, I would like to thank you all from on his behalf also. And I think let's now conclude this session. And thank you, everyone, and good night.
Thank you.
I hope I see you again in my future webinar. I hope you'll agree to come back again.
Sure.
Thank you. Thank you.
Thank you.
Thank you very much.
Thank you, sir. Good night.
Good night.